Why do cystic fibrosis newborn screenings have false positives? Imagine a test that is designed to catch as many cases as possible but sometimes ends up flagging babies who don't actually have the disease. That's what happens with newborn screenings for cystic fibrosis. These tests are very sensitive, meaning they're good at catching potential cases early, but they're not perfect at confirming who truly has the condition. The process usually starts with measuring a chemical called immunoreactive trypsinogen, or IRT, which tends to be higher in babies with cystic fibrosis. If the IRT level is elevated, the next step is genetic testing for common mutations in the CFTR gene, which causes cystic fibrosis. But here's where things get tricky. Elevated IRT isn't exclusive to cystic fibrosis. It can also happen because of other reasons like stress during birth, oxygen deprivation, or temporary organ issues. So, a baby might test positive on the first step even if they don't have cystic fibrosis. The genetic testing looks for specific mutations, but it can't always tell the difference between babies who carry just one mutation and those who have two mutations that cause the disease. Many infants identified as positive are actually carriers, meaning they have one mutated gene but don't have symptoms or the disease itself. Carriers are quite common and usually healthy, but the screening can't distinguish them perfectly. Plus, the genetic tests only look for the most common mutations, which vary by population. Some babies might have rare or unknown mutations that aren't included in the test panel. If only one mutation is found, it can lead to a false positive, prompting further testing. Another factor is how the cutoff levels for IRT are set. These thresholds are chosen to balance catching true cases and avoiding false alarms, but they can be too low for some populations. For example, certain ethnic groups naturally have higher baseline IRT levels, which can increase false positive rates. Some screening programs try to adjust for this, but it's not always consistent across regions. The entire process involves multiple steps, and while these protocols improve accuracy, they can still produce false positives due to variability in test performance and interpretation. Overall, about 90% of babies who test positive for cystic fibrosis in screening do not actually have the disease. Instead, they are either carriers or have elevated IRT levels for other reasons. Confirmatory testing, such as the sweat chloride test, is essential to make a definitive diagnosis. This test measures the amount of salt in sweat and is considered the gold standard for diagnosing cystic fibrosis. It helps prevent misdiagnosis and ensures that only babies with true cystic fibrosis receive the appropriate care. In summary, false positives happen because the screening tests are designed to be highly sensitive rather than perfectly specific. Factors like carrier status, genetic diversity, physiological stress, and the way cutoff levels are set all contribute to these false alarms. While newborn screening is a powerful tool for early detection, it always requires follow-up testing to confirm the diagnosis. If you have concerns or questions about screening results, it's best to consult healthcare professionals who can provide personalized advice based on the latest medical guidelines.